I'm going to ask my normal question. Can everybody see the slides?
Yes, bro.
Good, good, good. Okay, so we're going to talk about sort of nuclear medicine imaging and oncology. Now, clearly, in 2 hours, we're only going to be looking at this in a small amount of detail. We're going to do more in the advanced course. I do hope I will actually physically be in South Africa to do, but you never know, do you? So we'll see how things go. That will be next year, of course. So we'll have a little bit of a break in the middle. So I put a break in the slides so that we can just get up and walk around and deal with anything we need to deal with. It also gives me a chance to get the recording sorted out. So we're going to start off with single photon work, and then we're going to look at PET. Obviously, single photons got smaller and PET's got bigger. So it used to be that there used to be 1.5 talks on single photon and half a talk on PET. Then it went to 1 talk on each, and now it's about half a talk on single photon and 1.5 talks on PET. So the first thing is, whenever we're doing imaging in nuclear medicine, we need to know why we're doing it. And this is really important in oncology because it's all about when do we scan the patient? What are we aiming to do? Because with functional imaging, we are looking at things differently than anatomical imaging. And we are, though we have some functional resolution, we don't have the same kind of anatomical resolution as we see with some PET tracers. So, and then with things like MR and various things, you know, MR breast can pick up tiny things, 1 or 2 millimeters, which we can't see. So we do have to sort of understand where nuclear medicine is good, but also we need to understand where other radiological techniques are not good and how we place ourselves. So we could be used in diagnosis, but to be honest, our role in diagnosis can be a bit limited, but our main role probably is in staging. So trying to identify the extent of disease, particularly, for example, if patients are heading towards curative surgery. Restaging after treatment is an increasing area, and I think as we get more data, we will find that there'll be even more indications in that area. Partly the reason it's a little bit slow, of course, is that we need to sort of collect data about how that affects outcomes, and that takes a while. A very interesting area will be looking at predicting response. Can we use nuclear medicine techniques to say, yes, if you give this particular treatment, you're likely to get a response? That I think is a very interesting area because that's something which anatomical imaging is not terribly good at, this predictive thing, because it can't really look at cell function. And then obviously in theragnostics, we're looking at functional therapy. This might be radioactive or non-radioactive, but monitoring which patients should have that treatment and how effective it is. If you're using a functional therapy, by that I would include things like immunotherapy and radioligand therapy, then having a radioligand imaging system is a very good way to see what's happening with the patient. So all these are areas which are increasing. To be honest, our role in diagnosis is not really commonly done. There has been a bit of work with breast cancer using single photon techniques. People have sort of tried it with PET, but it hasn't really caught on. It may be that, for example, we are asked to do PET in cases where there's like raised tumor markers. We don't know what's going on. But I suppose the other area that we do get asked to do it is when we're looking at things like single pulmonary nodules. So you have an abnormality on a CT and you know, trying to work out what's causing that abnormality. So I'm going to talk about some single photon techniques. Now, some of these are a bit old and some of them you may not use anymore, and I have reduced this part of the talk quite considerably. But sentinel mammography may still have a role, partly because it's still able to do things that other techniques, even MR, can't do. And because it is functional, and it's particularly useful when there is dense breast tissue. So the advantages of it is that we use preferential uptake that have sort of a higher metabolic rate. And MIBI and tetraphosphamine are actually mitochondrial agents. So they're stored in the mitochondria of these cells. Now, you could think about using FDG, but one of the problems is getting a good view of the breast with FDG can be quite difficult. Now, we do sometimes see breast lesions with FDG. I reported one a couple of days ago that needed further investigation. But to actually sort of get to see the whole breast very easily, you need to sort of get very close and almost sometimes even compress the breast. And there are machines that try to do that with 511, but they've not really been taken off. So the technique that has been used was optimized in UCLA by Linda Diggles and Iraj Kalkali, and they use prone lateral images, which enable you to see the breast much more easily. So this is the image that they produced. In fact, it's not a perfect image because the couch thing is not being set up properly. And what you do is that you lay the patient on their front and you enable the breast tissue to fall away from the chest wall. And this is now very much the same position which you use in breast MR. We did a research project on breast PET MR, and we very much use the same kind of positioning, though the couch looks slightly different with MR because it contains coils. It's very important not to pinch or crush the breast for two reasons. One, it hurts, and secondly, it will distort the image. And if you're using sentinel mammography, you inject the MIBI or tetraphosphamine, and 5 minutes later, you take a 10-minute static image. Interestingly, when people looked at this, it has consistently delivered very high sensitivity, normally over 90%. And if you think the mammography is only about 80%, it does give you an idea of how good this technique is. The specificity varies depending on the kind of benign breast lesions. Some benign breast lesions like fibroadenomas have low-grade uptake of MIBI, but it runs between 60 and 90%. And again, if you take the most sensitive anatomical technique, which is MR, which has a sensitivity that's very similar, just over 90%, to do that, you're delivering a specificity of around about 10%, which means only 1 out of 10 lesions that MR identifies as cancer is actually cancer. 9 out of 10 are benign. So we do have the advantage with these functional techniques of having both high and low, high sensitivity and pretty high specificity, which is fairly unique. And this has all been proved by doing blind reads, multi-center trials, which is something that some of the other techniques haven't done. And the other thing is, because you either have uptake or no uptake, the results are very consistent. So in intra-observer reads, the correlation between readers is around about 90%. For the best series in mammography, for example, it's about 60%. And in MR, it's around about 30%. So the technique actually is pretty good. It's just not widely used. Now, here is a patient. Now, the other thing is, remember, a bit like kidneys, emission is different from transmission. So the breast points the other direction in an emission because you're imaging what's coming out, not what's going through. So here we have a mammogram of a patient with quite dense breasts, and you can't really see very much except the breast glandular tissue, and there's a bit of calcification, but it's not microcalcification, so it's not considered to be malignant. And here is the MIBI scan of the same patient, and you can quite clearly see in the MIBI scan that there is focal uptake in the upper part of the breast, which looks like a primary and 2 sites of disease within the breast, secondary disease within the breast. And when you look at the mammogram there, it's completely negative. So this is, and that's because the mammogram just depends on calcification. If the tumor doesn't cause calcification, it's negative on a mammogram. But you can see it with sentinel mammography. This is another patient. This is a 45-year-old woman with very dense breast tissue. And you can see how dense it is. And here we have the sentinel mammography. And again, this is the area where the tumor is. And you can't see anything on the mammogram at all. But here you can see very clearly the abnormal uptake of MIBI. So that's all I got on symptomography. I mean, if you want to read about it, there's lots of literature and there's even meta-analysis and everything. But I still don't understand why the technique is used as little as it is. There are other things that we can have where we have much more specific tumor targeting agents that's still single photon. We discussed some of these earlier on today with neuroblastoma. So for example, if you have tissue that expresses something called the VMAT gene, the VMAT gene is an active amine transport system, then you can get uptake of MIBG, methylbenzoguanidine. If you have somatostatin receptors, then obviously we can use single photon somatostatin agents, and there's a mixture of those. Deprotide is one that was used in the past, octreotide, and more recently we have the tectate and tectoc. Deprotide was used in lung cancer, but obviously doesn't have the same resolution as FDG. So what these mechanisms do is that you have a peptide carrier normally, or MIBG, the molecular carrier, which you normally put technetium on because it gives you the best imaging, and then you get receptor imaging. So we know that somatostatin imaging has been around again really for 40 years now almost. I'm trying to remember the first time I saw a scan. It was early 80s, which is now nearly 40 years ago. Oh, someone's getting old. Anyway, this was developed by Eric Krenning using originally iodine-123, but that didn't produce very good results. So in the late 1980s, 1988, he started to label it with octreotide, with indium. So he had indium octreotide, and that started to really change things, and we started to get very good results. And the octreotide bound to somatostatin 2 and 5 receptors, which are overexpressed in neuroendocrine tumors, and noted very early on a 90% sensitivity. And in a paper in 1993, not 2003, 1993, he published the results of the first 1,000 patients that were scanned with indium octreotide that confirmed an accuracy of over 90%. We now know that we can do better with SPECT-CT, and if you have PET, you can also use the gallium dotatate. If you don't have PET, then there's the technetium agents that you can use. So this is one of my patients who has a classical neuroendocrine tumor. So we got this patient has got a lesion in their abdomen. This is a mesenteric lymph node, which you can see has intense uptake of activity. And there's a second area of uptake, which is in an internal mammary node up here in the upper mediastinum. So very rapidly we can stage the patient. Interestingly, we thought originally this was a lung carcinoid, but on biopsy it was proved to be a small bowel. We never found the primary. These were just 2 sites of secondary disease. But the patient was treated for a long time just with somatostatin analog. More recently, we've been able to use Hynek octreotate, sometimes called Tectroid. The Hynek is a nicotinic acid linker that seems to work very well. It has particularly good affinity for the somatostatin 2 receptors like gallium dotatate. It was a lot cheaper, but the company that makes it's been bumping the price up recently because they can make a profit from it. So it's not as cheap as it used to be. Clearly, we have a lower radiation dose, and it's available now and licensed. So the development was slowed down by European legislation, but it's now much better. So here we have a patient with a tectroid, and we can see the first panel is of the liver, obviously. This is the tectroid scan showing multiple sites of focal uptake, and this is the CT. And you can lay one scan over the other, and you can see very nicely there's a pancreatic primary with multiple liver metastasis. And the image quality is not quite as good as you get with the PET agent, but it's not bad, and certainly good enough to plan for lutetium dotatate therapy, for example. People have looked at other peptides. This is glucagon-like peptide, which is particularly good at finding very small pancreatic tumors, in particular looking at insulinomas. And this is some work that was done at University College London. These are 4 different patients showing, this is sort of normal studies, and these are 2 abnormal studies showing focal uptake. And both these insulinomas were less than about 6 millimeters, which are difficult sometimes to see with somatostatin analogs, which tend to be negative in about 50% of insulinomas. So what about our role in staging? And again, I think this is our biggest role in ordinary nuclear medicine, non-PET nuclear medicine. And obviously the most common thing that we do is look using bone-seeking agents for bone scans. Most centers are still doing a reasonable number of bone scans every day. We were, before PET came and became widely available, using a whole range of non-specific tumor agents such as thallium-201, technetium MIB, and tetraphosphine, and gallium-67 citrate, all of which were developed actually initially as tumor agents, and then thallium and the MIB and tetraphosphine then moved over to be cardiac, and gallium moved over to infection. The one area where we still have a role is in sentinel nodes, and this I think has really stayed as a good use, though, even though there are now new agents with sentinel node using optical imaging and MR, nuclear medicine techniques still remain widespread. So I'm going to talk a little bit about some of the old things. So this is a patient who has a tumor in their cerebellum. This is a metastasis in their cerebellum. And in those days, we didn't have FDG PET, and we didn't have the fancy things like C11 methionine. So this is a patient who was imaged with thallium, and then it was registered not using a SPECT MR, but on an MR scan using a Hermes computer. So the sentinel nodes are more commonly used, and many of you may do sentinel node studies on a fairly regular basis. And this is based on the Morton principle. So there was a surgeon, Dave Morton, who in the 1960s said that there was a logical way in which tumors drain through their lymph node basins, and you could track this. And originally he did this with blue dye, and then again from the mid-90s onwards, radio tracers started to be used. And many people use a combination of both. So they'll do the radio tracer, and then they will do the blue dye just before the operation. And the reason is the blue dye shows up the tracks very nicely, which makes it easier to do the intraoperative probing. So if you think of blue dye as showing up your motorways, and then your radio tracer shows up your NGen service stations, I'm particularly thinking of that road between Joburg Airport and the Pretoria, which I used to travel when I come fairly frequently. And you can imagine that if you think of the service stations as the lymph nodes, you can find those with the probe, and then the blue lines that you get with the methylene blue are your motorways. It's very much easier then to find the nodes by just tracking along the blue lines till you hit a high signal. This was developed in different countries. So we had the USA group mainly based around Los Angeles, which is Dave Morton and Dr. Craig and Giuliano. And then in Italy, the European Institute of Oncology in Milan, and the Amsterdam Medical Center in the Netherlands with Kees Hofnagel. And all this was basically to try and remove the need to do significant surgery, like in the breast, for example, doing axillary clearance on every patient. So this is a little cartoon. This was from a paper by Cabanas and Dave Morton that was published in about 1962. And here you can see, this is the tumor, and then you have these different orders. So the first draining node is the sentinel lymph node. Now, for those of you whose language is English, American English for a guardsman is a sentinel. So that's why it's called a sentinel node. So it's like a guardsman guarding the rest of the lymph nodes. So sometimes I show a picture of a guardsman outside of Buckingham Palace. Though to be honest, just to let you know, they don't have any bullets in their rifles, so they're not really very good guardsmen. But never mind. You don't want guardsmen shooting tourists. That would be very bad for trade, wouldn't it? So there are second and third order nodes that you may also see, but it's the first draining node, which is your sentinel node. So the basic principle is you inject the substance in or around or near the tumour, depending on the kind of tumour it is. To be honest, you don't need to be that precise. The Dutch always like to inject in the tumour, but most of the other centres in their research just injected in tissues around the tumour because the lymphatic drainage is the same. You track the agent through the lymphatics, so you can do this with a gamma camera very nicely over time. And when it starts to stick in the sentinel node, you can even mark that on the skin if you want, or for many cases, we now do a SPECT CT, which is a very nice way of localizing it. And then when the patients go to theatre, the surgeon uses a handheld gamma probe to identify the sentinel nodes, which is then removed. Now, if that sentinel node, which is that first node, contains cancer cells, then there's a possibility that further down the line, the cancer's got into the second and third level nodes. So you go for a full clearance. If that sentinel node has no cancer cells in it, it's extremely unlikely, and we're talking around about 98, 99% unlikely that there's any disease elsewhere. So you don't need to do a training clear the basin. In fact, it's been recently shown that if you do have cancer out there, then it would have spread not by lymph tissue, but by blood, in which case doing the exudate clearance is still a pointless exercise. It has proved to be a very useful technique. Oops, sorry. So the agents used, as I said, first of all, was methylene blue. I thought I'd show you this picture of methylene blue. Because it's a very small molecule. In fact, methylene blue is actually based, did you know it's based on tamoxifen? I had no idea, but tamoxifen and methylene blue are almost identical, because one contains cobalt blue and one doesn't. So that's an interesting fact for the day, isn't it? So you inject about 30 minutes before surgery, and then visually they look for these tracks, and you can see these blue lines looking like motorways where you're trying to track your way to lymph nodes. If you did it on its own, you just remove the bluest nodes, but this only finds about 80% of sentinel lymph nodes. So the big change in the mid-90s was to use radiocolloids. Now, and you need to try and use colloids at between 80 and 300 nanometers. And that will be different in different countries, because different countries have different kinds of colloids. Most places probably use nanocol, but there is a version that's produced in France, nanocis. And in the United States, they can't use either of those. So they take ordinary colloids and they filter out using filter paper with 300 nanometer holes in it, any large colloid. So they use a filtered colloid. You inject this, as I said, around in the tissues around or even just above the tumor, which you can do in the breast. You don't need to go deep. And it's picked up by the lymphatics, which run under the skin. And for the breast, you can do about 30 minutes before surgery, as you can for limb and melanoma. Trunk and head and neck and melanoma may need to be a lot earlier, 2 or 3 hours. You can track with a gamma camera and then use a handheld probe. You find the hottest node. And by doing that, you get over 90% of sentinel nodes. And we now, with the improved technique, it's over 98%. And this was done in breast by Veronese and in melanoma by Dave Gillette from Australia. But it does require good coordination between people. So you need the surgeon to select the cases, do the probing, and remove and tag the sentinel lymph node. And maybe, if it's in a very difficult area, to inject the radiotracer, for example. I don't know how many of you want to do lots of cervical injections looking at cervical cancer, or vulval injections. We tend to tell the surgeon, give them the syringe, give them a bit of training, say, you inject where you want to, like that. Looking like down dark, dank perineum is not my idea of fun in the morning. But you may want to do that, it's up to you. Generally, for things that are on the surface, we can see, we inject the radio tracer, perform the imaging, we may mark on the skin, and our physics department may maintain the probes and keep the quality control of the probes going. And then you need a pathologist to look at the specimen, and if you're going to do it as a one-stage operation, look at frozen section, but that has fallen out of favor recently. So where to inject? Well, there are two types of injections you can do. Subdermal injection, which obviously for melanoma, they're all subdermal, or you can do peritumoral for breast or some other deep tumors. Most people use the subdermal because it's a lot quicker. And as even in breast, you don't need to be that precise. You can even get away with a areola injection in the quadrant where the tumor is, because all the lymphatics head straight to the skin and under the skin. So you don't even need to inject over the actual tumor. So this is some sentinel nodes of the breast, and you can get very nice pictures, and here's a transmission. So the other thing you can do to get a nice picture, a bit of anatomy, is use your cobalt marker, your cobalt, not marker, your cobalt flood, used for your QC, lie under the patient. It has a very soft gamma, so the patient blocks it, and you get an outline of the patient. You can also use a cobalt marker to do that, but I think this just looks a bit neater. That's the injection site, and there is the lymph node. You can see that nice and clearly. Intraoperatively, you can use gamma detection devices. Most centers now use Bluetooth because you don't have a wire getting in the way. And this is from a company called Neoprobe. And when you get close to the node with the highest counts, the counts go up. And to help the surgeons, so they don't have to keep looking at the probe, there's normally a sound on it, and as the sound goes higher, you're closer to the probe, to the node. And the other thing is that originally under the Cabanis and Morton paper, they said there was only one sentinel node. We now know that's untrue. There's often 3 or 4 sentinel nodes. What about radiation doses? Because there was some concern about radiation doses to surgeons because they don't really understand anything about radiation. You can tell that by the fact that they just endlessly irradiate themselves with fluoroscopy during operations. They looked at the radiation dose this is at University College London. They looked at radiation dose to both the surgeon and their assistant, and calculated it with the standard activity given for sentinel nodes. The radiation dose per patient was the wonderful 0.00034 millisieverts per operation. So you would need to have to do 300 sentinel node operations to get the same amount of radiation as watching 1 hour of television every day for a year. You need to do 60 operations to get the same radiation dose as a return flight from Frankfurt to New York, or 20 operations to get the same dose as smoking a single cigarette. So they basically said, don't worry about it. So they were told they had to have a limit. So using the 1 millisievert limit, that means that any surgeon can do 3,000 sentinel node operations per year. Well, that's never going to happen, is it? It was suggested, this is modified in 2005, that if they are pregnant surgeons, that they limit it to 100 per year. 2 a week. And this was also confirmed by more recent guidelines for head and neck as well. When they tried to measure the radioactivity to a pathologist, they couldn't find any, because obviously even though the lymph node is radioactive with a probe, the amount of radioactivity in each sentinel node is so tiny. When they started putting radiation detectors around pathologists, they just couldn't pick up anything beyond the background radiation in the room. What about to the patient? Well, that depends where you inject. It can be as high as 1.4 millisieverts, but most of the time it's much lower than that. A chest CT can be about the same level. Obviously, an abdominal CT is much higher. What about a fetal dose? Well, it depends again where you inject. So if you're injecting a melanoma that was on the abdomen, then obviously the fecal dose would be much higher. But if you were, for example, dealing with a patient who has a breast cancer or a truncal melanoma or head and neck melanoma, then the fetal dose from that injection is about 0.018 millisieverts. And that is the same as the fetus would receive from background radiation just living in the world for 1 day. So unusually for nuclear medicine, like lung scans, sentinel node scintigraphy is not contraindicated in pregnant women. And this is very useful because you don't want to delay operations. Now, under most rules, and for example, in the European Union, there would be a radiation protection advisor who can get very specific advice for a particular patient. The other thing we do is that there can be obviously some spillage, and we don't want to irradiate our staff. So any drapes or anything that's used during the operation, including the surgeon's outside gown that could have blood on it, they're all collected and measured. If they're not radioactive, they go straight off to the laundry. If they are radioactive, we just keep them in our radiation store for about a month, because that's our rules, but you probably only need to keep it for 2 days, and then they can go off to the laundry. So when do we use it? Well, routine for more than 10 years has been breast and melanoma. Many centers also look at head and neck tumors, particularly floor of mouth, vulva. A bit more experimental is cervix, prostate, and colon, mainly because you need to inject normally through scopes and things. And we find that for head and neck, either melanoma or head and neck primaries, SPECT-CT is very useful. Here we can see a nice coronal view with 2 sentinel nodes identified very nicely. And this is a floor of mouth, SCC. And you can see here, this is actually not with a colloid. This is another agent called tilmanocept. And you can see there's the injection site. And there's a submandibular gland you can see very nicely. And there's 2 sentinel nodes on this side. So it remains a very good technique. However, things all changed in the year 2000. Do you remember 2000? Some of you don't remember 2000. Some of you will remember the year 2000. Some of you probably only about 4. So 2000 was an exciting year. We were all meant to get the millennial bug, and planes were meant to drop out of the sky, and the whole world would come to an end, but it didn't. But what did happen was a chap called David Townend, sitting in Knoxville, Tennessee, invented a PET-CT scanner, which then added PET to CT. And in 2000, the Time magazine hailed this as the invention of the year. It enabled us to do attenuation, correction, and localization, and has completely changed nuclear medicine. And here's a picture of a PET-CT scanner. Now, can anybody recognize which hospital this is in? Stick it on chat or tell me. Anybody recognize which hospital's PET scanner this is? Oh, we'll see whether anybody comes up with any answers. I'll tell you at the break. So we had a discussion about this before with infection inflammation. So there are 2 pathways by which glucose is taken up in cancer cells. One is lactate driven, and the second one is this feedback mechanism that doesn't require high lactate, but there's an increased requirement for oxygen, and this feeds more glucose into the system, and this is known as the Warburg effect, and was first described in the 1930s. So we can use PET in preoperative staging. Somebody's come up with an answer. We'll see if they're right in a minute when we stop. So the New England Journal of Medicine, which is not the kind of journal that publishes rubbish papers, published a paper on PET and CT in the very early days, just as PET-CTs were coming in, looking at non-small cell lung cancer, and they compared histology with PET staging and showed that PET was significantly better than CT. And this is the kind of picture that this is a year 2000 PET-CT of an esophageal cancer showing staging with nodes in the neck. So it really made a big change. And this was the kind of pictures that the results from that study. And some of these were actually done on a PET scanner without a CT, and some were done on the new PET-CT. And you can see here that the sensitivity and specificity of PET was much better than the classical CT. This is some examples from a study that we published in the early 2000s. This is a patient which clearly you can see has got an abnormal chest X-ray. And as the consolidation cleared, a mass was seen in the upper part of the left upper lobe. And here is a big spiculated mass, but there wasn't much else you could see. There was no lymphadenopathy. But here you can see very nicely is the mass, which is FDG avid, and then there is a contralateral lymph node. So this is an N3 under the new TINM staging, which is inoperable. So that would not, if the patient had been staged by CT alone, it would have been operable, but it's now inoperable. This is another one with a base down, a mass down in the left base, and CT showed an enlarged window in the large node in the AP window, but this was not PET avid, and so it was downstaged. Whether or not people would trust PET alone, but it was a fairly chunky lymph node, so it was felt that it was unlikely to be due to cancer, and it's not in a site you can easily get to biopsy. So this patient was downstaged and went ahead with their operation and remained disease-free. So just before the break, I'm going to talk a little bit about lymphomas, staging of lymphomas, and these days we base this on TINM 8, which is also known as the revised Lugano. And there was a big step change from TINM 6, which was published about 15 years ago, and particularly with stage 4 disease. Now, before the latest revisions, which started off in around about 2008, 2009, stage 4 disease was disease above and below the diaphragm, but that's now moved to stage 3 if it's limited to the lymph nodes, bone marrow, and spleen. And one of the reasons for changing the staging was that PET picked up more disease than had been seen previously. And it was found that the patients who PET picked up small lymph nodes on the side of the diaphragm did better than those who had disease that was extranodal. So they changed the staging at that point. So most of you would have been brought up with a new staging, as I call it, which is staging that was different than the CT-based staging that existed before PET became much more common. So here we have a stage 1 diffuse large B-cell lymphoma, and in stage 1 you see this, the disease is limited to one site. So in this case it's all axillary. So this is a stage 1 disease. This is my picture's face is hiding this. This is a stage 1 disease. You can see there's lymph nodes here in the abdomen, but the spleen is active and you have a higher uptake in the spleen than in the liver. So we would count that as active splenic disease. So this becomes stage 1. Now, some people call it 1E and some people call it 1S. And unfortunately, there is some confusion over whether it should be S for spleen or E for extranodal. And some hematologists like to use S, some like to use E. But I think describing it as spleen is much more useful, because extranodal would mean it's outside of the reticular endothelial system and would infer actually stage 4. This is stage 3 disease. So this is quite extensive nodal disease involving the right-sided axilla, nodes in the neck and the mediastinum and the abdomen, but no extranodal disease. And this is in a youngish female patient. But this stage 4 patient has much lower levels of nodal disease. It is within the chest and the abdomen, but has liver involvement, but no splenic involvement. So this is still a stage E effectively, but because under the new staging system, extranodal disease outside the spleen and bone marrow is counted as stage 4. So this becomes a stage 4 lymphoma. Looking at response has become another really interesting area with lymphoma. I'm going to do this in a lot more detail in next year's more advanced course, but we're just going to give you some ideas of what we've been doing. The easiest way to do that is to compare the pre and post therapy scan and use the SUV to help with decision making. How does that change? But the problem is SUV can change for various reasons, including uptake in other organs, such as in the bone marrow with anemia. So we tend to use a reference site, which is blood pool and liver. And this is based on some work done by a hematologist called Hutchkins and a nuclear medicine professor called Sally Barrington at St Thomas's Hospital. And they also developed something called the Adobo criteria. And this does not need a pre-treatment scan. And the reason for this is many patients may be diagnosed and treatment initiated in a peripheral hospital without PET-CT, and they come up to the main hospital to have a scan and their treatment further down the line where a PET scan is available. In the UK now, we try to ensure that there's always a pre-therapy scan, but that may not be possible in areas where access to PET is limited, in rural areas, for example. The other thing is we want to avoid FDG uptake in inflammatory tissue, so we try to do the post-therapy scan 6 weeks after the final treatment. And this is some very old-fashioned work that was done by a chap called Jerusalem. And this is a Kaplan-Meier curve of survival of patients who, at the end of treatment, were PET negative and PET positive. And basically, if you're PET positive, your progression-free survival is measured in weeks. If you're PET negative, your progression-free survival can be measured in months and years. So as I said, the idea is to put together some criteria. So they had this consensus conference in Deauville in France, and this developed the Deauville criteria, which has also been absorbed into Lugano criteria. Lugano criteria can also include CT. So this is remained pretty true. So you use mediastinal blood pool, normally in the arch of the aorta and liver, and the SUV there is used as your sort of reference rate. So if you don't see any uptake, then it's a Deauville 1, that's a complete metabolic response. A little bit of uptake, but less than mediastinum. That blood pool, that is, that's a Deauville 2, which today is also considered to be a metabolic response. Then 3 is uptakes more than mediastinal, less than liver. That to some degree is considered to be a partial response. And then 4 is uptake, which is more than liver, but just moderately. And 5 is significantly more than liver. How you measure that, most people go for an SUV 1.5 times liver. So liver tends to be around about 3, so an SUV of around about 4.5 or above. And a Deauville X is new areas of uptake unlikely to be lymphoma, and these honestly tend to be infection because these neutropenic patients can get infection. So 1 and 2 is counted as definitely clear. So this patient had Hodgkin's disease and has a significant reduction of the activity. However, this is clearly a Deauville 4 because you can see the uptake in the lymph node is definitely more than liver. You can see that on the MIP image without doing the actual SUV. This is more subtle and initially looks really good, but when you look very closely, you can see there's a focal uptake here in the spleen, which is more than liver. So this is also a Deauville 4. So despite that, this is the only site of disease. The prognosis of this patient moves into the poor prognosis group. When can we do early evaluation? Various different studies have been published, and most now agree that after second cycle is the best, though you can see a response after first cycle in many patients. And here we have a 25-year-old having induction chemotherapy for Hodgkin's, and you can see multiple sites of disease on the first scan, and the second scan after a single dose of chemotherapy shows significant reduction. Now, the tumor is still there, but it is responding, so the uptake is reduced. So we're not telling you that the patient is tumor-free, but we're predicting that they will have a good response. There's a study between Italy and Denmark looking at 290 patients with Hodgkin's with 2 cycles of ABVD, and they compared that to using things like lactate dehydrogenase level, LDLH, And they compared that with FDG PET. And what they found was that it didn't matter if your international prognostic score was high or low. It was PET that determined your overall response. So if these two curves are PET negative, it didn't matter what else you had. The lactate dehydrogenase level could be high or low. But if your PET was negative, you did well. If your PET was positive, you did badly. So I'm going to have a break there. So the first thing I'm going to do is I've got to stop sharing so I can stop the recording. So I can store that.